screen, which should be this one. Yep. Cool. And then I guess we have, so I guess hello everyone. And then we have like, we can continue with last week's case, which is an interesting case, but probably a very unusual case. Or we have kind of a new case, which is, in my eyes, a lot more common, and a very interesting case. And it came through the prior practice. So I would vote for going for the new case, and then if we have enough time, we go back to the last week's case, or we keep it until we have enough time to go. So the case I'm referring to should be case number 69. I think I will share in a second. I'm having issues with this window that decided to go away. Okay.
Morning, all.
Okay. Hello.
Morning, James.
Okay, so let me go here. Okay, I'm gonna share the link to the case in 1 second. Otherwise, it's case 69. Okay, and I'll give you the history in 1 second. Okay. Okay, here we go. So let's go to the chart. That's the link to the case. And then the history, this came through prior practice. So if, and I can't remember who sent it, but if there is anyone there that knows about the case and wants to introduce the case, please feel free. Otherwise, I just copy that part of the information that I got, not everything in here. Okay, so I share the link. You should be able to open the images. I will open the images in a minute, but otherwise, it's an older cat presented a couple of weeks ago for reduced appetite, and the main finding on blood was hypercalcaemia and azotaemia. So I think it went through an abdominal ultrasound and they found something abnormal, and then based on that, they decided to go and do a thoracic study, and that's what we are going through today. So let me bring the case. Okay, here we go. There are 4 images. I'll probably get only 3 because there are 2 DBs. They are both very good, so we can just live with 1. And then we have left and right lateral projections. Okay, so not very specific history. I mean, going through the history, there wasn't anything specifically kind of respiratory. And it was based on an abdominal ultrasound that they thought there was something abnormal in the thorax. And this is what we now see in the radiographs. As usual, take a minute. Again, you can open the link in your computer, play with the images, or just look at my screen. And then we start with the findings, and then we try to explain what is going on. Normal or abnormal?
Abnormal.
Abnormal. Well, the obvious thing is the right side of the thorax is on the VD is quite radiodense, but the vascularity, might be imagining it perhaps, seems to me to be more obvious on the left lateral and the chest. The caudal lung fields on left lateral are possibly a bit less obvious than on the right lateral, but that could be imaginitis.
Well, that's good. So I think the first obvious statement, but I really like how you define it, because it, in my eyes, kind of brings, it's telling us an approach to the case. You said there's an increased opacity in that right hemithorax, and I like that as a first statement, and not committing, makes sense, not saying, well, that thing, what, we shouldn't really jump and go very fast in saying, well, that increased opacity, I mean, there are multiple options. Could be the wall, could be the glass space, could be the lung, I suppose could be the mediastinum. You know, there are multiple options. Could be something from the abdomen. I mean, I don't want to give you all the possibilities. I want you to start thinking about them. But the approach, I like it. It's very simple. Is that hemithorax is wide. There's fluid or cells. There's something going on there. Then the next step, I suppose, is gonna be, can we go a bit further? Can we try to figure where is it anatomically? Makes sense, and sometimes we can't. So probably I like that statement because that's how I approach it usually. Like when I don't know, and then I said, and I use exactly the same word. I use is this hemithorax. I'm not giving you more. I'm not telling you exactly because I don't know. Then I can probably start arguing, or we can go through and decide what is most likely and why and no. But the approach is like that. There's more wide in that hemithorax. It's extremely descriptive, and is for now not committing. And now the next step is going to be, the question is, can we commit? Can we decide first? Is there anything else that you want to mention? And then it's going to be, the exercise is going to be trying to decide where is anatomically, and then the following step is going to be, well, how can we explain it? You know, which kind of disease process can result in this?
The left hemithorax has also got an interstitial pattern, particularly caudally. It almost verges on saying nodular interstitial. That's probably sticking the neck out a little bit.
Okay. Do you want to show us what, in particular, I mean, the interstitial is a hard one to pinpoint, but you mentioned the word nodule. So do you want to show us where you think there may be a nodule? If you want, if you don't want, that's okay. It may be just a feeling, you know. Okay, good. I completely agree with that.
Mariano, what was the age and breed again?
Or domestic short hair.
12 years old.
12 years old, yeah, so topic. Okay, here we go.
Hypercalcaemia and azotaemia.
Yeah.
Can I add as well that I guess one interesting part about the hemithorax whiteout is that on the VD you can't see the heart. There seems to be effacement completely, and it looks like a relatively straight radiograph. So I assume there's, I can't remember what you described it as previously, but almost like a mass effect where it kind of draws in, like a collapse of a lung lobe, that kind of thing, where it draws in a structure. And the same thing goes with the diaphragm on that side. There's effacement of the diaphragm. So I guess that implies that it's more likely to be fluid or soft tissue opacity, given those two structures are effaced.
Okay, so two ideas here. I would probably separate them. One, I agree with both. So one is that there is effacement of the right contour of the cardiac silhouette and of the right hemi diaphragm. So if there is effacement, then we can conclude that whatever is in contact with those structures is the same opacity. Makes sense? Because that's the rule. Two structures of the same opacity in contact, then we erase the border. So this is exactly what is going on here. So the only probably new information that we know is that they are in contact and that is soft tissue. The problem with the soft tissue situation is the soft tissue category is a very broad one. Makes sense? It could be fluid, could be mass, could be cells. It could be anything. Makes sense? But probably the only thing that we are saying here is that it's not gas and it's not fat. Then probably the other one I find it more interesting. And it's the idea that whatever is in that hemithorax is not acting like a mass. In a sense, it's not displacing the heart. So whatever, and that in my eyes is extremely important information. Makes sense? So it's not that we put something there and then it's big and it's growing and it's pushing the heart away. Makes sense? So there is no mass effect. That is a very important point. And now I think that is probably should help us keep on exploring. You know what? That's a very important condition. So I would probably mention the shape is the shape of the hemithorax. Makes sense? The opacity is soft tissue and is not producing a mass effect. What could it be? Or yeah, keep going. Any other finding?
Yeah, I think the liver might be enlarged with a rounded border.
Okay, good.
It's a bit irregular up on the top there in that one.
Okay. Yep, I agree. There I would probably be a bit careful because I think here you are probably getting the stomach. So I think that, I hope you can see my arrow. So let me double click. Well, so I'm pretty sure this is the pylorus and that's the colon. So I will not use this as the contour of the liver. This is the contour of the liver. So based on that, it's probably not that abnormal. Here I'm not sure. Here I don't know. Is that stomach? Is that liver? I don't know. Is that spleen? I'm pretty don't know. The only thing that I probably we could add with some degree of certainty is that if we come here, and if we believe that this, I think because there's a little bit of gas, so this should be the left lateral. That makes sense. Okay, so left lateral, we push fluid into the pylorus, so now we can get to decide if that is pylorus or liver. It makes sense based on the opacity. And if we conclude that that is the pylorus, then the gastric axis is kind of okay. So that is telling me that if I have a question mark, it's probably less likely for that border in the other projection to be the liver. Hopefully you could follow my reasoning, is that we have this structure, we don't know what it is. I think there's a little bit of gas in the left lateral projection, therefore we make it pylorus. And therefore we question that the liver is enlarged in the right lateral projection. That would be my thinking aloud about that finding. I love that you are looking into the corners and there you are trying to, like a detective, gather information from every angle, because that's basically what we are doing. We are trying to solve a problem, and the more information, even if it's in the periphery, the more we have, the better position we are going to be to solve the problem.
Could you try and get some pleural fluid?
Okay, good point. So how
the boundary of the lungs on the cranial aspect looks a bit rounded, so and it's lifted. There's space between the sternum and the lung, so you may have a chance of doing that.
Okay, good point. So how much, and I love that you mentioned that, because my next question is going to be, well, probably the obvious one is, that's why I love that you mentioned here, because I think you are already answering my question, but we need to put it out. So one option for this increased opacity in the right hemithorax is there is all pleural effusion. How likely do you think that's the case? And that goes for everyone, makes sense? So increased opacity in one hemithorax, one differential is, could that all be pleural effusion? Can we know? Should we forget about it? Should we stop and say, well, we don't know? Tell me how you walk through that option. Is it possible? Is it not possible?
I think it would have to involve, the lung would have to be filled as well. And I guess would pleural effusion, and this is more of a question, like would that push the heart as well, given that it's a space, unless you're collapsing the lung, I suppose, and that's taking up the space there. But I imagine if you had, like in this case where we can't actually see lung lobes very easily, so we had lungs filled or collapsed, marked pleural effusion, we might see the cardiac silhouette pushed more to the left, but I'm not too sure about that. That's just my thoughts?
I would sign that thinking aloud process. I would agree in everything. So, and again, it's not 100%. It's not that in every case, the ruling is going to be there, but the hints that you are pointing to are perfect. So, if it's going to be in the pleural space, and now I'm not talking about the comment about the left cranial lung lobe, so the separation of the lung from the wall in the left cranial thorax. Sorry. I'm now talking about the hypothesis of whatever is going on in the right hemithorax to be pleural effusion. So if we want to play that game, then what would be expected are these two things that you were mentioning. One is that usually there is nothing in the pleural space. So if we're going to add more stuff, then we usually want to see a mass effect. Make sense? Like more if there is fluid. So the expectation of having a mass effect, I sign that is there. Then I like that you say, well, what if that the space that the pleural effusion is occupying is taken from the lung? Makes sense? What if the lung is completely empty and that space is replaced by pleural effusion? And I have nothing to say. That's a perfect thinking. The only thing that I would probably add is that I would think that's a relatively unusual situation. Makes sense, where you have a complete atelectasis, so complete, based on a primary. So let me rephrase that. I think it's unlikely to have something producing a primary pleural effusion, and that being so severe, or a mechanism, or resulting in complete atelectasis of one hemithorax and not mediastinal shift. So if you're going to increase the pressure, what I think is going to be happening is you're going to have a mediastinal shift before you collapse all those lung lobes, the right ones in this case. So perfect thinking that it could be, we cannot be 100% sure that this is all pleural effusion plus complete atelectasis of the lung lobes. I think based on the lack of mass effect, mediastinal shift, and the complete absence of any border suggesting that there may be a lung lobe there, I think it's less likely. Okay, so hopefully the thinking is visible there. Any other option? By the way, before we continue, I completely agree with that comment about the pleural effusion on the left. I think there is minimal, but there is separation of the lung. There may be a pleural effusion line there. So yes, going and getting the pleural effusion, and I completely agree with the comment. Not so much, and there are no clinical signs, so not so much as a therapeutic thing, not so much about removing pleural effusion for the animal to feel better, but as a diagnostic procedure, trying to get the cells out of those and then do cytology. I completely agree with that comment. But okay, what else could it be? How else can we explain the changes in the right hemithorax?
So off that same train of thought, Mariano, if complete atelectasis or collapse is unlikely, but with the whole grapes thing that you taught us, that like if air and fluid were in the same level, you would be able to see a lot more defined structures. Does that make it more likely that whatever this is, whether it's an effusion or not, is actually in the lung? Because if we expected some air in the lung, we'd be able to see some kind of air compared to fluid border.
Exactly. So I like that. So then the other consideration could be, what if now it's not that we have two components, not that we have pleural effusion plus lung. Let's for a minute play the game that we have that whatever soft tissue structure is in that right hemithorax is all lung. Or at least there is a disease that is resulting in displacement of all the gas within the lung. And now we have soft tissue within that lung. And then in that scenario, we can even have pleural effusion that will be silhouetting or no pleural effusion if everything that we see in there is lung. Make sense? So if we play with the hypothesis of that being lung, then I think in my eyes then we can have a bit of pleural effusion. I don't no issue with that. If the lung is very severely affected, there may be pleural effusion. But then because the primary mechanism is going to be the lung all that right lung being affected, then we can explain why we don't see any lung border, makes sense, any separation of the lung from the wall. And in addition to that, as you pointed out, that could also explain why we don't see a mass effect. Makes sense? So whatever is happening in that lung is replacing the air with fluid, but it's not large enough to act like a mass and displace the heart away, for example, or the mediastinum. So in my eyes, that hypothesis is closer to what is going on. And I don't, this probably a good report would just describe what is happening and then have different paragraphs hypothesizing one possibility, another possibility, and another possibility. I would probably, this would be a long report. Like the description would be a very short description because we went through, there is increased opacity in the right hemithorax, there is no mass effect, there are possible nodules in the thorax, and then we haven't gone into the abdomen, but that would be the description, very easy. Now the interpretation of that, there are multiple ways to interpret this. One was all the pleural effusion. We talked about that, why I think that's unlikely, and to make it as a summary, I think it's unlikely because there's no mass effect, and we don't see any hint of the border of the lung. So then the second hypothesis, I like the second hypothesis being, well, there is something in that lung that turned that all those right lung lobes, the disease process turned them into soft tissue. And probably the disease process kept those lung lobes with the same overall volume, and that's why there is no mass effect. Any other hypothesis?
I was going to say this is not a hypothesis, but on the left lateral, I'm trying to look at it and talk to you at the same time, but look at it in the bigger pictures. You've got lots of changes in the right lung lobe that I would have thought if it was just pleural effusion, you wouldn't actually be able to see those changes. For example, you've got air bronchograms and you've got what looks like a mass at the tip of the ribs. Now, if it was just fluid in there, I don't think you'd see all that.
Do you mind showing me that?
Well, yeah, that's a good question. I'm going to try.
Okay.
Well, I'm not sure you can see that.
An extremely important point, and the important point is, how can we reconcile all the images? Is there something that doesn't fit? Makes sense? And the way I would say is that there are very severe unilateral changes. And how are the lateral projections showing us what we expect to see, or there's a mismatch? So very interesting discussion. So in my eyes, I don't see a mismatch, but that's why I'm asking you to show me what is the image that you see on the lateral projections that they don't fit with what you see in the DV projection, and we try to clarify that.
I can't. I'm sorry. I'm not familiar enough with this. I can't do it. I've just tried, but I can't.
But tell me if it's the right or the left.
It's at the left lateral, and it's
So
what I.
And now, where is that?
Okay, take your cursor to the right, up a bit and about there. No, not so far. Down, down, left, left, there.
Okay, good. Anyone willing to offer an explanation for that? And I agree with you, it's there. There's something wide, rounded, relatively well defined.
I think we can see it in all the views. I think we see it in the DV and the other lateral. And it looks like an isolated nodule. Well, it's the most nodule looking thing I can see that. Yeah, I can't really see any other obvious nodules other than that one.
I would agree. So in this case, I would say that this is likely that.
Okay.
Unlikely that. now, but you open kind of a nice door, and I think it's worth discussing. Where are these severe changes in the other projections?
Yeah, I can't see them at all. I think when you're looking at the left lateral, I feel like you should see less, you should see more opacity because you don't have an aerated. So when you're looking at the left lateral, I feel like the opacity should be different, but it looks like both laterals, you can see a similar amount of air in the chest. So it looks like you must be just aerating the left lung and both laterals. But I thought it would look different when you are lying on the affected side to the unaffected side. But they look so similar, I can't explain the mismatch. I can see more fluid. It looks like there's greater fluid on the right lateral, but it may just be positioning. But I feel like there's a big mismatch that I can't find where the opacity has gone. Is it just fluid that's shifted, or is the left lung expanded so much that you see it on the left lateral?
Good, lovely. And it's good that you put your frustration out, and then we'll try to explain it. But so I guess now we can either have someone trying to explain that, attempting to give an explanation. Otherwise, I may take a note, and then when we come back to that, but it may be a good time to start trying to explain. So this is a lot of hypotheses one after the other. Makes sense? Because again, the findings are very small. They're important, but it's not a long list. And then we went through the hypothesis about, where could it be? And now we need to even go further, and let's play the game and say, let's assume from the discussion, I think it's more likely for all of that to be lung. So we can play the game and say, let's assume that is the lung. Which kind of disease process can result in disappearance? And then we can play the game and think, let's assume that this is pleural effusion, and then which disease process can result in disappearance? And then the next question is going to be what to do next. And then we come back to try to explain what it appears like a mismatch in between the projections, okay? Let's play the game like that. So what kind of disease process can result in disappearance if we assume that this is all lung?
We know we can't see air bronchograms on the DV, so it can't be, and also it's unilateral, so it can't be like congestion, because we're seeing their air carrying bronchi also filled with the same opacity as the alveolar tissue. So it either needs to be fluid which is in the bronchi or tissue which is in the bronchi.
Excellent, excellent. Very good point. I will have an exception to that rule. So I may say it now. An alveolar pattern is characterized basically by the increased opacity, and sometimes 98% of the time by an air bronchogram. But an air bronchogram is not necessary. Make sense? So if you have, like, I don't know, an example would be like a severe hemorrhage, pulmonary contusion. So there's so much fluid in that lung that is also going to the airway. That is still like a lung low. That's a wet lung, and it's so wet that now we don't have air in the airway. Okay, that is still the disease process is just fluid within that lung. So I completely agree, and your thinking process is perfect 99% of the time where we want air bronchograms. But remember that it's not a necessary feature. It's an almost there feature, but it's not a necessary feature. The strongest feature from what you said about this, the stronger argument, you were arguing against this being edema, I think. And then the stronger argument in my eyes is not so much that you don't see air bronchograms, which I agree is there, but I'm insisting that it's not necessary, but the asymmetry. it would be very unusual to have such an asymmetric distribution, and also a hemithorax distribution. Makes sense? So you may have the right caudal more affected than the left, but it would be very unusual to have the right cranial so much affected or as severely affected as the left as a right caudal. Makes sense? So the distribution is really not there for edema, for example.
Well, if it's not
Any other disease process that can result in the whole right lobes looking white?
You've got chylothorax or hemothorax or a neoplastic infusion or an infectious inflammatory infusion. Is that where you're going with all this?
Well, those are good options, but those options are going to be pleural effusion. Those are going to be diseases that result in first pleural effusion and then atelectasis, which perfectly fine. I think we should consider them. I'm still going around the idea, which kind of disease process can result in the whole right lung, all the lobes in the right being white.
Would things like so yeah, you already said hemorrhage, so I guess that could be things like a contusion from, I mean, there's no rib fractures, so I'm assuming trauma's a little bit less likely, but possible. Neoplasia would be one, definitely could cause bleeding and fill up the lung lobe, would fit also with the hypercalcaemia potentially. And I'm not sure.
Lung lobe torsions.
Yeah, torsion was the next thing I was going to say. I'm not sure.
You have to have all of them.
Good option. So and you're gonna hate me, but I'm gonna put in the position of trying to find issues with your ideas, okay? But that's the way to select the right idea. The issue with the idea of the torsion, even though it's a beautiful one, is that usually it's one lung lobe. It's not the whole. I mean, all the lobes. I like your comment about contusion. Then I also like your comment about why that is unlikely. No rib fractures, nothing in the wall, no pneumothorax. So it seems to be an extremely severe but isolated finding in terms of trauma. And I really have nothing to say about your comment about could it be neoplasia? So, and I really love how you went on and say, what if the neoplasia is bleeding? And now we have like a neoplasia that is bleeding within the lung. And then that lung is all fluid filled, which is the bleeding within that lung. Makes sense? That sounds like a very good option. And that could probably explain why we don't see the classic mass. So the classic mass would look like, I'm gonna draw now. So the classic mass should look something like this. Okay, so that's the textbook mass. And it's usually soft tissue, and it's usually surrounded by aerated lung. And that's why we see the borders. Make sense? So, and that's like this one, like this nodule, or that nodule. So that's the classic situation. Now you're bringing another situation. You're saying, what if we have a mass, and then the condition is the mass is now bleeding. So then that blood is extending into the rest of the lung and also against the mass itself. Makes sense? So now, and the mass could be very small. Now the mass is small but bleeding like there is no tomorrow. And then is filling that right lung lobe, those right lung lobes with fluid. And then that's the reason why they silhouette with the cardiac silhouette and they silhouette with the mass itself. And I don't have any argument against that idea. That idea is a very good idea. And then that idea could also explain, depending on where you locate that mass, could also explain the distribution of the changes. Makes sense? Because if the mass is affecting, or your theory needs that mass to be able to bleed in the airway. Make sense? So if you put that mass in the airway and you put it high enough in the bronchial tree, then it can easily affect one side of the lung. Makes sense? All the right lobes and not the left lobes. Is that okay? So you don't see the mass, but if you put something in that airway up in the bifurcation, as it goes into the main right lung lobes or pulmonary main principal lung lobes or principal bronchi, then you can explain everything that is happening. There is one more mechanism how something like a mass up there could result in disappearance. So it's not the bleeding, but it's the obstruction of the airway. Okay, so if you have a mass growing in that bronchi itself, and it's not only bleeding, but it's also obstructing the airway, you're gonna reabsorb all that gas. Makes sense? There's no more gas exchange, and then that air is gonna be reabsorbed. And based on the localization that we're assuming that is up in the airway, then you can explain this unilateral distribution. Okay, so if you go in the book, they're gonna say, you know, something that is lower in distribution or affect one side of the lung, then basically you need to be thinking about something either in the vessels or the airway up. Makes sense? Up where there is that division. And then differentials to consider are in an older cat with hypercalcaemia, it's going to be obviously neoplasia up there, or it could be if it's a young animal, whatever, it could be a foreign body. But I want to go back to the thinking about pleural or lung, and then if it's in the lung, where should that thing be, and which type of mechanism should it have to obstruct either the airway, to bleed within the airway, or to affect the vessels. Makes sense? That's kind of the thinking that it should be there. And that, in my eyes, this is, and then if you put this together with a cat, that is an older cat, this is how most of, not most, I don't know in percentage terms, but this is a very common presentation of bronchogenic carcinoma in cats. So it's not the classic lung mass in dogs, where you have like that mass that is well-defined, rounded like a football. You know, that's in dogs, and that's a carcinoma. Usually is not extending through the airway. Cats with bronchogenic carcinoma, it's bronchogenic. It grows along the airways and basically results in obstruction and bleeding within the airways. And this is not the first case that I see like this. So do I see it? No, I'm not sure I see the mass, but it's the explanation that there is something in that airway obstructing the air passage and probably bleeding and affecting that all the right lung lobes, probably with a minimal pleural component, if there is a pleural component. This has no question. And then there is a met. Makes sense? So everything really fits in place for something like a bronchogenic carcinoma. I hope I'm not going too far and too confident, but and that's why I wanted to remind you that we got a case like this. Now I'm back again lost. Okay, here. If you go back, and I'm happy to show you the CT on that case because it's a very similar case. So we went, it was I think case 18, if I'm not wrong. No, it's not 18 here. So if you want to review that case, that was exactly a bronchogenic carcinoma, and we went through a CT. And I show you the radiographs. Oh, I'm not showing you. This is the radiograph. In that case, this lung lobe affected all this side, not as much. So there is some degree of air in there, but this is the appearance that we got. And then I'll show you the CT, and let me show it to you because I think it's worth seeing how it extends through the airway. And I think it's going to help you understand what's going on. And again, this is not the same dog, animal, cat, but I'm pretty sure we are dealing with the same disease process. So this is a CT with contrast, different animal. And I'm going to basically concentrate on a dorsal projection. So it's like looking at the DB radiograph. So here it is. Okay. So right, and this is opposite, makes sense? So the affected lung lobes in this cut are the left and not the right. But see, so
Oh dear.
reduced volume, increased attenuation, normal right side, and then if we, let me go more, okay, dorsal, ooh, there we go. So if we follow the airway, okay, good, so let me go there. This is gonna be a trachea, okay, here, and you will see that it goes to the right lung lobes, it's open, no problem. Makes sense, main bronchi to the accessory, right caudal, right middle, no problem. If we go on the left, we follow it for a little while and it collapsed. Makes sense, in more than collapse, there is something replacing that. There is soft tissue within that airway. And if we follow it more, okay, beautiful. So this is, look at this lung. So this lung, basically, this is the pulmonary vein, this is the pulmonary artery. To this caudal left caudal lung lobe, which is soft tissue, like in our case. And this is gonna be the airway in between the vessels. And the airway is all replaced by a soft tissue material. Make sense? So this is like this is like this. So artery, vein, airway. That's a normal airway, normal bronchi. In the affected side, the lung is smaller, there is soft tissue opaque, and there is soft tissue material within the airway. Okay, and this is probably part of the mass. So the mass really grows here, it walks through the airway, and then results in a mass there. Makes sense? So it's really a neoplasia that extends through the airway. And by doing this, obstructs the airway, and there's also bleeding. And that's why it results in, basically in a dog, we will probably have gas around that mass. And then basically we would see a mass, what we call a mass, like a soft tissue structure surrounded by gas. In this case, the mass is surrounded by either a telectatic lung or lung with fluid. Make sense? And therefore, we don't see the border of the mass. We just see that lung lobe that is not aerated, usually small, like in our case, or normal in size. Is that thinking all right? Is this helping you to kind of visualize what is happening? It's just a neoplasia that is growing through the airway. And then all the consequences of that neoplasia going through the airway, which are going to be part of it bleeding, part of it obstruction. And what we are missing is going to be what our usual expectation in terms of pulmonary masses, which is our ability to see the mass surrounded by aerated lung. We don't see, we usually don't get to see. In some cases, we see it in cuts. I'm not saying that every case is going to work like this, but in some cases, it just shows up like this. So coming back to our case, is that okay? And in this case, it really grew through the airway and it went into the mediastinum. But basically, this was a bronchogenic carcinoma. And you can see how it resulted in atelectasis of those lung lobes. It was just because the neoplasia was growing, extends through the airway. So,
Mariano, can you explain why we don't see, I guess, a worse lateral view?
okay, good. So now that is we have two questions missing or still to answer. One question is this kind of mismatch in between the projections. And the other one is, if you are in this scenario, what to do next? Because I was showing you a CT, but if you don't have a CT and you are at this stage, what can you do to support your hypothesis? You know, how can you prove that you're right? So in terms of what it seems to be a mismatch, remember that when I don't know, I should go through the cases, but remember that the differences in how much we visualize like a focal mass in the lung, depending upon the projection, if it's right or left, it relies or needs to have the soft tissue mass surrounded by aerated lung. If you just erase all that lung, makes sense, and then the amount of gas in that lung is not going to change depending on positioning, then the expectation of having this, or let me rewind and go even back. So if you have a normal animal, let's start with a normal animal. So you have an animal with the two lungs working okay. So in that scenario, when you put it on the side, there's an immediate partial atelectasis of the dependent side. It's not severe, it's partial, but enough to make the visibility of those vessels reduced compared to the ones that are up. And we had a paper that we showed that with one of my residents in Sydney. So, and then if we turn the animal the other way around, it's not going to take 5 hours. It takes nothing, 10 seconds. Again, there's going to be a partial atelectasis, mild, but enough to challenge your visibility of the vessels or a focal lesion that will be there. That is like a phenomenon that happens relatively fast. And now I'm going to speculate that it needs both lungs to work okay. Make sense? Because they need one to have the compliance to get a bit larger, and another one the compliance to get a bit smaller. Make sense? So they need to be at that interplay between one getting a bit larger on top, the other one getting a bit smaller on the bottom. So that, I think, is the mechanism. If in that mechanism you are like a focal lesion, then it's obvious that the focal lesion is going to be better visualized, or the vessels themselves, when they are up, because there's going to be more air surrounding them, and therefore the visibility of that structure is going to be increased. Now, I think we are dealing with a complete different situation. I don't think that those rules apply in this case. Now, this animal is only working with one left hemithorax, with the left lung lobes. So I'm not sure how much this play between atelectasis is happening if we are only relying on one lung. And maybe the mechanism, the mechanics of respiration are going to avoid that lung from collapsing when it's on the dependent side. And I'm speculating about that. And then the other thing that I would add, trying to explain why this is odd, is that remember that we are speculating about a mass growing in the airway, and then that mass growing in the airway is surrounded by fluid in the lung, or fluid or soft tissue material. It makes sense, either bleeding, atelectasis. So basically, in none of these radiographs, we see the border of that mass. So then there is no expectation, because nothing really changes depending on recumbency, to change that. Makes sense? So even if we put the cut on the right or on the left, it's always going to be, that mass is always going to be surrounded by soft tissue. So we are not really changing anything to change the appearance. You may argue and say, well, I have the expectations of the vessels to look different between the right and the left. And I agree with that, and I'm not sure I know how to clearly explain that. The way that I would run, I would go and say, well, for that phenomenon to happen, we need two normal lung lobes. Makes sense? So there, one is, the volume of the thorax is kind of, it doesn't really change. If one lung lobe gets smaller, the other one gets larger. If we don't have that compliance in the affected lung, in the right, then maybe the left that never really changes. That would be my argument. Why we don't see the usual, and that I'm guessing. Where I'm not guessing is in saying, if we assume that there is a mass in the airway, I clearly know why we don't see it. And the reason why we don't see it is how I showed you in the CT. That mass is going to be surrounded by fluid. And then that surrounded by fluid is going to happen regardless of the recumbency. And that's why I don't have the expectation to see it in any projection.
And we're only looking at the left lung, both laterals.
Yes, correct.
Yeah.
Correct.
Yeah. Right. Okay. Cool.
Well,
we did get diagnostic.
You need to trust what I'm saying. I'm pretty sure, but there's a degree of trust.
We got aspirated what looked like pus from the solid lung that we thought was actually a granuloma, and we aspirated just some modified transudate pleural effusion, but that had carcinoma diagnosis, and the other was just a necrotic mass, necrotic lung tissue.
Yeah, so that in my eyes fits perfectly fine. And basically what happens is once you have that airway that is obstructed, then there can be areas of pneumonia as well, and even areas of granulomas. Makes sense? So the neoplasia obstructs the airway, and then there could be a superimposed infectious inflammatory process. So that fits. The comment that we still have and should be considering now is what if next time we are in this situation and we see something like this? Let me just mention one thing before we go, or before we go in there, and is I will try to pose a case about pyothorax, and that is going to be all in the pleural space. The images may look relatively similar, but I think we are good enough to separate. And I'm going to try to bring a case, and we try to compare both situations. And you will see that what they may share is that the unilateral or asymmetrical distribution. The point that they will not share is that in a pyothorax, we somehow, that accumulation of fluid in the pleural space in sacs, let's say in focal areas, is not even distribution, always results in some degree of mass effect. And it always results in us seeing that border of the lung being displaced. So I promise I will bring a case and we can put one against the other and try to learn more about when we have this asymmetric distribution, what are the hints? So we can try to see if it's more pleural or more lung. So I promise we'll do that. The other thing that I want to mention is let's say, and let's go back and go as far as saying there is increased opacity within that left hemithorax. And let's assume that I don't want to speculate anymore. So I don't want to speculate if it's in the pleural space. I don't want to speculate if it's in the lung, anything. What to do next to learn more? And the answer is ultrasound. Makes sense for a radiograph. That white in that right hemithorax is the same regardless if it's pleural effusion, if it's a completely fluid-filled lung, if there's a mass within the lung. For a radiograph, for the X-rays that are going through the cut, those tissues, that interaction between the X-rays and those tissues, all of them, effusion, mass, something in the lung is the same. So most of the time we are not going to be able to separate. For ultrasound, the interaction, the physics behind interacting with fluid in the blood space, interacting with fluid-filled lung, interacting with a mass in the lung is going to be different. And probably one thing to mention is that this is the ideal case because the problem that we have with ultrasound is that we cannot go through gas. But in this case, that whole right hemithorax is either mass or fluid. So it's the perfect scenario just to put a probe. And if you put a probe, calls like, is it all pleural effusion? Is it part in the lung, part in the pleural effusion? Can I see something abnormal in the lung? Those comments, I think by putting a probe, you will be able to answer. Those questions are you're going to be able to answer. So you're going to be able to confirm, if you were hypothesizing that we did, you're going to be able to confirm that hypothesis. Otherwise, you're going to be able to find something different, and you could also sample. So this is to put this case into a clinical scenario, so you don't need to go that far as we did. I have a lot of fun going that way and trying to find hints and little things that are telling us, and also this is a very interesting pathophysiology if you want, but you don't need to go that way. So if you see these, probably you can consider the differentials and then say, well, actually the best tool that I can use, the best and cheapest and least invasive and less risky, doesn't need anesthesia, anything, it's just put a probe there. And then you will be able to separate a lot of the differentials that we consider. Ideally, if you're planning to treat for CT, is also justified. You get a better picture about the overall disease. Can I confirm that there are mets? Probably in this case, I don't need to confirm, but that will be the reasoning.
Great, thank you.
So I don't know if you, was it okay, the thinking process? Are you happier now?
Yeah, it makes complete sense.
Okay.
Went from understanding it at all to getting it.
Good. I love these real life cases. Yeah, it took me a while to find the other case yesterday. I spent like an hour trying to find that CT, and then I realized that we already talked about that one. So for anyone interested in this particular kind of pathophysiology of obstructing the airway and what is the result and all that, we can go back to that discussion where I think we went more in detail about the CT. And even though, so okay, what I could try to do is to, if I can, because I don't know if we have the ability, is to upload the CT to that case. So then you can review the radiographs and the CT together. Should be case 18. I may have promised to do it and never did it, but I will put a link to the CT. So then I think it's the time that you spend trying to understand anatomically what is going on. And these are two very similar cases. So if you open the radiographs, try to explain them, and then going slowly through the CT, back and forth, trying to see what is actually happening, I think that's beautiful. It helps for the understanding. So I promise I'll do that.
Cool. Thank you.
Very awesome.
That would
Yes,
be
thanks, Mariano. Just really useful. Brilliant. Thank you.
very
Yep,
nice.
enjoyed that one a lot. That was good.
Awesome. So we'll see you next week.
Okay. See you then.
Enjoy your week.
Thanks,
Okay.
Mariano.
Thanks, Mariano.
Mariano.
Thank you, very interesting.
Thank you. That was
Good.
difficult. Thank you.